Hi, good afternoon, everyone. Welcome back to another unit discussion. This is our unit 3. So we're going to be talking about drains and catheters today. There are quite a few of those that we're going to go over today. We talked a little bit last week about a few, but we're going to go into a little bit more detail today. So our objectives are going to be to demonstrate the knowledge of these varieties of supplies. We're going to go over suture and sponges at a later date. That's also an objective for another unit, so we're going to talk about those later. We're going to focus mostly on our drains, catheters, and dressing material today, because you as a surg tech are going to be in contact with those on a daily basis, okay? You're going to help the circulator and the surgeon put those on those patients if they're dressings, or make sure you have the right types of catheters, etc. Okay, so our assignments for this week, again, another discussion post that was due technically yesterday, because today is Thursday. So make sure you're getting those in on Wednesdays, and then your response by Sunday. All right. And then something I keep noticing with a lot of you, I know it's only a couple points. Maybe you're just like, it's a few points, I don't care. Those points can add up if you're not citing your sources in APA format. So you're going to see that in all of your classes. So I would encourage you to just take that extra effort in making sure you're doing this in APA, okay? All right, so let's get started with our drains and catheters. What's really the difference between a drain and a catheter? Sometimes I think those terms are used interchangeably sometimes. And sometimes we just call certain tubes a drain, and sometimes they're called a catheter. So as a student, that can be a little confusing. I understand that. But typically a catheter is going to be used in most cases to drain, sorry, my air just kicked on, to drain things like urine or blood from within a vessel, perhaps. And a drain is typically something we're going to place after a case to drain any excess fluid that may come from maybe what we've done. Like, we'll put in a drain if we expect there might be some oozing, some extra bleeding that we want to make sure doesn't build up inside that patient. So that's kind of the difference, and you'll see when we get into some of these really what the true difference is when they come to their use. So let's start with drains. Broadly, the two main types of drains are going to be active and passive. So if a drain is active, there's something attached to that drain that is literally pulling or sucking out that fluid, all right? It could also be removing air, but typically we were talking about fluid here. Something is attached to the tube that will draw that fluid out, okay? So that's one category. The second one is passive, so it's the opposite. There's nothing that's going to pull it out. It's really just going to let gravity do the work, and it will trickle out. Usually if we're not expecting large amounts of drainage, passive is okay. But if they suspect there might be, a lot more active bleeding, a little more drainage buildup, they might want this active one that has something attached to it that would collect that fluid as well, instead of not just pulling it out, but it collects it. With a passive, you're going to have to put something on the end of it to collect the fluid as it drips out. I'll show you a picture of that here in a minute. So drains in general are used to remove fluid from an incision, like I mentioned. It could also be removed to remove air from a chest cavity, fluid from the common bile duct. I'll show you a picture of that. And any type of these can vary depending on where we're working, what's the anatomy like, what's the actual surgery, maybe patient, weight or their specific anatomy might play into that, and the type of drainage, like I said. Okay, so let's get into some of these specific active drains. One of the most common ones you're going to see is the JP. Okay, JP stands for Jackson Pratt drain. So it is active because look here, it has this little bulb, or sometimes they call it a grenade. It's a grenade style type of active drain that is empty when you put it on, okay? In this first one, it's completely empty. To activate it, that's what this picture is showing you. To activate it or to let it suck out fluid, you squeeze it with this top port open, this emptying cap open, okay? Squeeze it, Now this has already been placed into the patient here. It doesn't show that, but that's where the tube goes. Put the little port thing back on after you've squeezed it. That basically creates negative pressure in this grenade or the bulb. So if you don't squeeze it, you don't squeeze this collection reservoir, there's no active suction. Okay, you have to put negative pressure in the bulb for it to literally start sucking it out. Okay, and once it starts to fill up, that air is replaced with the fluid, the blood, and then if it gets too full, you need to empty it by just reopening that top cap, squirting it into something acceptable. Okay, and I'll just put it in the trash, and then starting the whole process over. So typically these hold about 50 to 60 mLs or cc's. So keep that in mind. If you ever have to empty one, let your circulator know. Maybe you're getting ready to send the patient back to PACU or something. Let your circulator know if it fills up pretty quickly. They're going to want to probably tell the surgeon if they're still in the room. Tell the surgeon, because that might indicate there's still some very active bleeding within the patient, and the surgeon may need to go back in and address that if there's a lot of bleeding even after they've sutured the patient shut. So keep an eye on these. Don't let them fill up. Okay. And this second picture here just shows you the two different types of JP drains. They can be flat or they can be round. So always verify with your surgeon what they prefer, a flat JP or a round. They do come in different sizes, like a 7 French. So always double check your sizes. This blue strip is actually radiopaque, which means it does show up on X-ray. And if you notice, if you look closely, there's tiny little holes here along this end section. This portion is the part that stays inside the patient. And then at the other end, you can't really see it in that picture, but that's what gets connected to that grenade. So these holes are going to be where the fluid is collected from and goes into the tube. Then on the outside over here, you can kind of see it. Most of these drains are going to be secured to the patient by suturing them to the skin. You'll have usually a silk suture or something like that. They'll tie around the drain really good, actually throw it into the skin, make that suture pass, and then tie it off and then cut the needle. Okay. So similar concept to this next one. This is called a hemovac drain. Same type of end, really. The drain is different. The reservoir, we should call it, is bigger. So a hemovac drain holds a whole lot more. If they're expecting more type of drainage or fluid to come out, they may prefer a hemovac because it holds way more. So this one pictured is 400 mLs. I've also seen up to 500, so it just depends. But the concept is the same as that grenade of the JP. You're still going to have to activate it by squeezing it. This one's kind of like, they call it an accordion style. You're going to squeeze it shut so it's compressed to create that negative pressure. The tube gets hooked up here. You're going to close that collection port. That creates the negative pressure. This part right here that I'm pointing to, it looks like a metal spear. It really is. That's the part that's going to puncture the skin. The whole part still goes into the wound, wherever the drainage will be. And then this part gets basically pushed up through the skin to create an opening for it. And then it will get sutured to the skin. And this sharp part gets cut off and put it in your sharps box. It's super sharp, obviously, going through the skin. Okay, another type of active drain is called a Blake drain. So it is very similar to the JP, but if you look closely at the end, it is shaped differently. It could still be hooked up to that bulb grenade though. All right, so the tip is different. It actually has 4 collection channels, and it can be flat or round as well, but there are some benefits to this. It's a little more resistant to clogging, and I think it's even a little bit easier to take out of the patient later, as opposed to the JP. So I just wanted to show you that slight variation there. So like I just mentioned before, active drain preparation. This one in particular is the hemovac. So let's say it's full. You're going to open that collection tube or the stopper, pour it out into an acceptable container, squeeze it shut, and then replace the stopper to create that negative pressure. Okay. Another type of active drain you'll see pretty often is a chest tube. So chest tube's a little bit bigger, a little bit more involvement when placing a chest tube. But here are some things to remember. So it not only just removes blood, it can also be used to remove air or pleural fluid from that pleural space. The pleural space is any of this surrounding the lungs. Pleural means lungs, right? So you can kind of see where it's placed here. This third little bullet star here is super important. That's a common certification question. I've seen it a lot of times from students and writing questions. But what's the purpose of a chest tube? In theory, it is to reestablish, they're calling it intrapulmonary pressure, is to reestablish negative pressure in the thoracic cavity, okay? The reason for that is, if you remember from anatomy, you have to have negative pressure in your thoracic cavity for your lungs to fully expand. If you don't, there's nowhere for your lungs to go. So if there's been any type of incision or maybe trauma to the thoracic cavity, that negative pressure disappears. You basically let the air out of the balloon, right? We need that air to stay in the balloon. We need that negative pressure. So this draws all that out, and then it will seal back up. Okay, that allows the lungs to fully expand again. So it could be blood, fluid, pleural fluid. There's a tiny bit of fluid in the space normally between the linings. Okay, so this shows you approximately where it would be placed. You could have multiple. You could have one up top and one down below. If you have two on the same side, the one on the bottom is used to drain fluid, and the one on the top would be used to drain air. We're gonna let gravity, obviously, fluid would go to the bottom. Okay. So here's a picture of one of those. This particular one is called a Pleuravac. There's a couple varieties. This is one we just use pretty often in my neck of the woods. So you'll see this version, I would say, pretty often, because it's a hard, big plastic piece that has to stay below the level of the patient for it to work. You never want to raise this above that chest level, or it's going to go backwards into the chest. It's going to defeat the purpose. You don't want that. So here's where that tube comes from the patient. Going to start trickling down into here. Additional drainage. And then it's kind of got this water seal for suction control to this direction. You can even hook it up to wall suction, but be careful that the suction you're using is not too strong for what you're doing. You can't use, if you use, it's called like a Neptune suction machine. If you're using that in surgery, you cannot hook up chest tubes to that. It's too powerful. So be careful with the amount of suction if you're hooking it up that way. Okay. So I just wanted to show you what that looked like. All right, so let's move on to some passive drains. These, again, are going to be used if you don't expect a ton of drainage because it's not actively drawing it out. It might just be like a slight trickle, something like that. So super common when you're going to see is the Penrose drain. These also come in a variety of sizes, and typically by size, I mean the diameter here. They could be very thin, like the diameter is small, or quite large, maybe 2-inch diameter Penrose. These are latex. A lot of these drains and catheters are latex, so be careful with that. Always check your patient allergies. If they have any sort of latex allergy, you'll have to find either a silicone or maybe a Teflon version of those types of drains. So this is what it looks like. It's obviously, it's actually kind of to scale almost. It's maybe a little bit bigger. So it can be used in a wound that looks like this. Okay, they're gonna make a small incision just off to the main incision line. They like the drain to come off the main incision line, so this incision line heals separate. So they'll place it into the wound. They can cut this to size. Does not have to stay the entire length of that Penrose. So sometimes the Penrose is only cut to a couple inches. That's all they need. Okay. Same idea. They're going to suture it in place. They're going to just lay it, maybe even throw a suture in deep into the incision, suture it in place. And then they'll also place like typically it's like a 4x4 dressing sponge at the end of this Penrose as it exits. That way it has something to drip onto so it doesn't get gross everywhere. Okay. We also, just to throw this out there, we also use Penrose drains to retract the spermatic cord. I don't know if you've learned that yet in any of your classes, but if we're doing like an inguinal hernia repair on a male, the spermatic cord runs right through where that inguinal hernia is. So in order to identify it and retract it to protect it, we actually will loop a Penrose, a moistened Penrose around that spermatic cord to retract it out of the way. So it's just, it works perfectly for it. So sometimes you'll see things you have kind of a double use. All right, another type of passive drain here is called a T-tube, and it is shaped like a T. Odd, right? So this T-tube is used to drain the common bile duct. So I tried to show you a picture here of how that really looks. Sometimes if you're just looking at this, like, I don't understand how that fits in there, right? They can cut it. In this picture, it makes it look a little bigger than what it truly is, okay? So the top of the T is going to go into the duct. The common bile duct, remember, comes off the liver. So if there's any sort of damage, or maybe there were stones were working on the liver or something, they may put in a T-tube, suture it in place, bring it out through the abdominal wall that way. Okay. All right, so that was really it for our drains. Let's transition over here to catheters. We did briefly talk a little bit last week about types of I think more urinary catheters. We're going to get into some of the others here because, and it probably is a misconception a lot of times when we say catheter, a lot of people go straight to thinking like to drain urine, right? A urinary catheter. They have a lot of uses. So it's not just urinary. We could put them in the GI tract in a lot of places for gastric, into a vessel, vascular, or for dialysis. Maybe the kidneys aren't working. So let's go back to urinary. The most common that you will see is an indwelling catheter. Indwelling means it stays placed somehow, and usually it's a balloon. So this Foley catheter, and I have a picture of it here in a few, is inflated inside the bladder, stays in place, and drains urine that way. A non-indwelling, sometimes it's also called intermittent catheter, intermittent. It's not needed all the time, you just place it as needed. Or sometimes it's also called a straight catheter, or straight cap. So that is most commonly a Robinson red rubber catheter. There is no balloon that keeps it in place. If you put it in the bladder, you better have something to catch the urine because it's going to come right out. Okay, so have a basin or something. And also in this category, you're going to have suprapubic catheter. So this supra means above. Okay, sometimes if, let's say, the patient had surgery on the bladder itself, or something happened to the urethra, cancer, who knows? There's a lot of ways that this could go, but they may have to make an incision through that the pubic area, directly through the bladder wall itself, and place a catheter instead of going through the typical urethral route. So this is more invasive, this type of catheter. And these two, the Mailcott and the Pezar, don't typically have a balloon that inflates. There's another way. I have a good picture of it. Another way they stay in place up against the wall. So I'll show you those. So gastric could be anywhere on the GI tract, but typically you're going to talk about it in the stomach, or maybe just below that in the duodenum or jejunum. But we could put in a gastrostomy tube or catheter. Sometimes it's called a PEG tube if we go through the skin, percutaneous. This could be used to provide nutrition directly to the stomach, or it could be used to decompress the stomach. Maybe the stomach needs to rest. Same concept here with the NG, but it's going to go through the nose, the nasogastric tube. A type of nasogastric tube is called the Levin tube. So you may hear it called either or. And then if you're going deeper, further down the GI tract into the jejunum, that's an NJ tube, a nasojejunal tube or catheter. Okay, vascular could go into a central venous line, or could be a peripheral venous type of catheter, depending on the patient's need. Maybe they need vascular access. For these, for central, the Grishong and PowerPort, are for these types of patients, maybe they're on chemotherapy or they have long-term therapy that they don't want to just keep sticking them over and over again to maybe draw blood or put in medicine. So they can put these, they kind of burrow under the skin, but they gain access into the vessel. So you'll see those. Dialysis can be one of two ways. It could be a peritoneal type of dialysis or extracorporeal. So extracorporeal means just means outside the body. That's all that big term means, outside the body. Peritoneal dialysis is using a catheter that goes into the peritoneum, the abdomen. And your peritoneum actually makes a really good filter. So you will filter the kidneys that way instead of the kidneys having to do the work. Maybe they are not functioning. Maybe they have kidney disease. So the Tinkoff is kind of like circular, kind of curls up a little bit in the abdomen for peritoneal dialysis. All right, so let's talk a little bit more about these indwelling urinary catheters. So this is how the whole setup looks if you haven't ever seen one. So this orange tube is your Foley catheter. The balloon rests right on the where the urethra exits the bladder itself. These two horn-looking things, now that I look at it, are the ureters. That's where the kidneys would be up here. Okay, from the kidneys drains into the ureters, into the bladder, and then the balloon. And if you look closely, has two little eyelets or openings at the end of that Foley. That's where the urine drains into. So none escapes around this balloon. Okay, goes into the tube itself, and then the bag, again, like the chest tube, needs to be kept at the level of the patient or lower, so you don't have any backflow. It could cause infection, UTIs, kidney infections if you don't let that drain. You don't want that. So keep it low. There is this extra little port coming off the side to inflate the balloon with sterile water. And then the tube itself hooks up. This tube here goes to the bag. There's a couple of ways they can look. It can have kind of a big, harder plastic piece, kind of like the chest tube. It looks similar. But the whole point is to collect the urine and to measure it. So there will always be markings to see how much urine has been drained. And then there's always a valve to empty it. So never send a patient from the OR to PACU with a full urine bag. That's not cool. Don't do that. You can empty that into an appropriate container, tell your circulator how much. And also they need to know approximately what the color looks like. If it looks like it's bloody, if it looks like there's blood in the urine, that could indicate that maybe we damaged the bladder or the ureters, and maybe we weren't really working in that area. So they want to keep track of those types of things. So here are your catheter tips. I told you there would be at least a decent picture. So I said the Pezar in the male cot didn't have the balloon that inflates. These are good for suprapubic because these stay the shape that they are. Okay, this male cot, or sometimes it's called a wingtip, and sometimes the Pezar is called a mushroom. Doesn't say that here, but they are. They stay that shape. They do not like decompress or deflate or anything. So you wouldn't want to use something that large shoved up the urethra. Okay, it won't work. It would be very painful and probably cause a lot of damage if it even went. So they do not go in the urethra. They're suprapubic catheters. Now I will tell you, I've also seen the Pezar or mushroom used as a gastrostomy tube, and we've made an incision into the stomach and use that as a type of gastrostomy. So you could see it that way as well, but never in the urethra. These you could. The Tiemann and Coudet are very similar. This is kind of exaggerated, but they're curved tips. Robinson does not have a balloon. That's your straight, but it looks similar to your Foley, but the Foley has the balloon. Okay. All right, so let's transition into some dressings. Got our Band-Aids here. So when we're talking about dressing material, there are a lot of things to consider. You need to consider what is being dressed, like what's the wound, okay? How well does this patient heal? If this is an elderly patient, sometimes their skin is a little more thin. We may want to take that into consideration when we're putting tape on. don't want to rip their skin just by tape. That can happen. Allergies, sometimes they're allergic to certain types of dressings. So those are all things to consider. Burns are going to be dressed differently than your typical surgical incision. So I wanted to show you some of these wound dressing classifications. You have your traditionals that you'll see most often. Examples, look at some of these names, your gauzes, your cottons, even plaster, they put plaster here. Skin substitutes is basically like a skin graft. So where it says example, allograft and xenograft, those are skin grafts. Okay, allograft would be from another human, xenograft would be like from another animal. And then your interactive dressings are like a film or a foam, maybe, that will act literally into the dressing, into the incision. And then your bioactives is like alginate, which is got like some silver in it, algae that all will help promote healing, hydrocolloids, really helpful in promoting wound healing. So advantages and disadvantages to all. So what should the ideal dressing look like? What's our goal here? You want to make sure it's clean. You want to keep it clean. Obviously, you don't want to cause more infection or any issues for the patient. You want it to be moist, but not too moist in that it doesn't heal. So there's a fine line there. Removes exudate. Exudate just means things that are draining out of it. Okay. So maybe it was some sort of absorbent material. A barrier for pathogens. You don't want anything to get in it that could infect it. Application and removal should be relatively painless. Some patients are a little more sensitive to that than others. Fill the cavity with no damages to perilesional tissue. You don't want to do any damage to surrounding tissue. And ensure hydrogen and gas exchange. That just promotes wound healing. Okay. So here are some examples of your traditional surgical dressings. You'll see these all at some point. A lot of surgeons still focus heavily on the gauzes, your traditional gauze. A wet to dry dressing is pretty common, where you wet some and it helps pull out some of the damaged disease skin, I guess you could say. You might actually even also have a combination of some of these, a couple different types of gauzes with some sort of sticky over top, a film. Okay, so transparent films may not have the gauze underneath. You could just put it directly on something. Like if you've ever had an IV, right? They're probably just going to put some sticky film over it to keep it in place. So it's not good for anything oozy, like a lot of blood coming out. There's no absorption. Okay. You've got your foams, which are nice. They're kind of padded. They might have an antibacterial right in it. These hydrogels could be good for burns, same with hydrocolloids. And then some of ours are multi-layer in that it might have these traditional gauzes with something sticky right on top to go right on that incision. So that's what this is here. It's a multi-layer dressing, and each layer has a purpose. So this is one example. Some may only have 3 layers. This one, they have approximately 5 here. So the bottommost layer would be what's in contact with your wound. You're soft. It shouldn't stick to the wound. You don't want it to make it worse, adhere to it. They have, in this one, not all of them have this, dispersive layer. And then the middle layer is typically your absorbent layer. And that's what's going to keep it from oozing even further past the outer layer. And then this outermost number 5 layer they have, it says it's fluid repellent and that it minimizes what's called strike through. So strike through is when fluid passes from one side to another. Okay, we don't want that. Want it to repel anything on the outside and keep anything, underneath it in. So there's no passage of bacteria. So I wanted to throw in a couple like types of, or ways you'd see some of these dressings, because it's not all cut and dry, okay? And this one especially, because This is called a Queen Anne's thyroid dressing. It's a little unique that we would place after a thyroid or maybe even a radical neck dissection or something on the neck. Because the neck can be a little tricky to place dressings. You don't want it too tight, obvious reasons. You don't want to cut off their breathing. And they move, people move their head around. So it's a little tricky. You have to put that gauze underneath the absorbent layer and wrap around the neck. This is actually tape. This crisscrossed part is tape. And then remember what this particular drain is called. That's JP drain. So you can see already how much, just at the end of the case, how much has been drained out. So keep an eye on those. So another multiple layer dressing may not be as cut and dry as some of the others, but this one has this yellow in letter A is called zero form. It's a type of non-stick dressing. It's got, this particular one has like an iodoform type antimicrobial, I guess you could say, directly impregnated into it. And a lot of our orthodox like this type of thing. This one is actually after a skin graft or like a cancer removal, I think is what it was. So place that down first. It doesn't stick to the skin. Over here in letter B, you have Telfa. Telfa is a non-adherent type of dressing or could be used for specimens. C is an absorbent layer. So that's a nice absorbent gauze. And then something to secure it. So this has no sticky on it over here in C. How does it stay in place? You can put tape completely around it, tape their entire hand up. But this patient, in my opinion, the reason why they probably did it this way, not just for comfort, but this patient looks to be a little bit older. Their skin is thinner, and frequent taking the tape on and off of skin can damage their skin very easily because it's so thin. When they bleed, then they have all these other issues. So you don't want to do that. You could use this over here in D, which is Coban. So it's kind of self-sticking. Whoever has seen Coban, you could wrap it around for some good compression, but not too tight. And it keeps it in place, but doesn't stick to the skin. Sticks to just the dressing. So that's kind of pretty handy. That's Coban. So another type of dressing is called a bolster dressing. So this patient had a skin lesion, looks to be cancerous, removed, and then a skin graft placed on top. So this right here in letter D is an actual skin graft. They took it from another part of their body, cut it to size, and then sutured it in place. When they suture this on, they're going to put big gauze pads here and tie these black strands over top of it to put pressure. So a bolster dressing and a pressure dressing are very similar in that aspect. You don't want this skin graft here in D to get any blood, like as it oozes, any blood up under it, it will lift the graft away from where it needs to be. So you want pressure on it so it doesn't get too bloody under there and it doesn't take, essentially. So here's how it ends up looking once it's healed. This one actually looks pretty good. A little change in skin color, but that's nothing. It's not too bad. All right, one more that really wasn't listed in any of our other categories here is a wound vac. It is a type of it's usually black, it could be silver, sponge that gets hooked up to a machine. But these sponges are cut to size. So if you have large or deep type of wounds that are having difficulty healing maybe, or there's no way you can put a skin graft on yet, or there's no way you can suture it shut. So they need something to put on it. So that's a wound vac is a great option for this because you can cut it to size and it promotes healing. It's going to draw out the fluid, but it's going to promote healing. So the sticky gets put over it, creates like a little suction, and the tube here gets hooked up to a special machine. Okay. So those are our drains, catheters, etc. So if you have any questions on any of those, please feel free to reach out to me. I do have office hours on Tuesdays. If that doesn't work for you, just let me know. We could try to work something out, okay? But hopefully you guys have a good week, and we're almost halfway through this quarter, so keep up the good work. All right, bye.